Complications of the CSOM we have continued in the next lecture, starting from the CSF autoria. So now what is CSF autoria? As the name suggests, autoria is the ear, and when the fluid comes from the ear, that is called autoria. And which fluid? As the name suggests, it is the CSF, that is cerebrospinal fluid. So it is most common with chronic otitis media. When the cholesteatoma is there, so there will be bone erosion will be there, tegment dehiscence will be there, and middle ear or the posterior cranial fossa dural tear will be there, and from there the CSF will be leaking. It is also iatrogenic, can be during the surgery also. The presentation are the clear colorless watery fluid from the mastoid cavity or the extra-aortary canal or through the nose in intact tympanic membrane. Middle ear myringotomy fluid is rich in glucose. Now proper exposure, temporalis muscle or fascia graft with gel form compression is needed. Synodural angle tear most difficult to control. Repair via intracranial route, extracranial, extradural or intradural. Brain fungus. Prolapse of the brain into middle ear cavity or the mastoid due to erosion of the dural plate. It is common in pre-antibiotic era, rarely seen now in resistant infections. Diagnosis is CT scan of the temporal bone. Treatment is removal of the necrotic tissue and a replacement of the healthy proposed brain into cranial cavity and repair of the bone defect. Now, subperiosteal abscess, that is extension of mastoid infection through the cortex and air cells into the subperiosteal region. The types of the mastoid abscesses are the subperiosteal abscess proper, which is the most common. Then this von Bezold abscess, then Luke's abscess, that is meatal abscess, zygomatic abscess, Cittalis abscess, or para or retropharyngeal abscess. There in hematogenous spread, there will be perforators, especially in the children. Differential diagnosis we have already studied in the previous one, like the mastoiditis without abscess, suppurative lymphadenopathy, infected sebaceous cyst, or superficial abscess. Now, what is pathogenesis? Will be production of the pus under the tension. Then there will be hyperemic decalcification plus osteoclastic resorption of the surrounding bone will be there. So there will be subperiosteal abscess formation will be there, penetration of the periosteum and then to the skin. And from the once the skin is broken, there will be fistula formation. So here in the picture you can see the post-oral fistula, that is subperiosteal fistula. That is also called the cortical fistula also. Now here in the picture you can see mastoid, near the mastoid cavity from the tip cell there is Bezold abscess. Then from the superficial subperiosteal abscess from the lateral wall of the mastoid antrum. Luke's abscess will be the meatal abscess. Zygomatic abscess from the zygomatic cells. Parapharyngeal or retropharyngeal abscess from the peritubal cells. Here you can see in the picture the postauricular abscess, which is the commonest. It is present behind the ear, and as you can see in the picture, the pinna is pushed forward and downward. Now, what is Bezold and Cittalis abscess? What is the difference? Bezold abscess is the neck swelling over the sternomastoid muscles, and the Cittalis abscess is the neck swelling over the posterior belly of the digastric muscle. So, as you can see, the ones in the neck here, first there will be posterior belly of digastric, and later on, lateral to it will be the this sternocleidomastoid muscle. So we can see that Cittalic abscess is little anterior and the basal abscess is more lateral and the posterior. Now, which are the DD of the Bezold abscess? That is suppurative lymphadenopathy due to upper cervical lymph node. There can be parapharyngeal abscess. There will be parotid tail abscess, infected branchial cyst, or internal jugular vein thrombosis. What is Luke's abscess? That is swelling in the extra-aortary canal. Zygomatic is the swelling anterosuperior to the pinna plus upper eyelid edema. And parapharyngeal and retropharyngeal are due to spread of pus along the eustachian tube. Now, what are the clinical features and the treatment? Late features of the neglected chronic otitis media. CT scan can show to the extent of the lesion, intracranial and intratemporal complications. Subperiosteal abscess with cholesteatoma, we have to do drainage of the abscess, we have to do cortical mastectomy and give higher IV injectable antibiotics. When it is without cholesteatoma, then only drainage with cortical mastectomy, IV antibiotics, or we can also do drainage plus myringotomy plus IV antibiotics, or aspiration plus myringotomy plus IV antibiotics. Now, other complication is mastocytitis. It can be acute or coalescent. Mastocytitis is mucositis of the mastoid cavity and air cells plus effusion. It is a part of the spectrum of uncomplicated otitis media. Per se, it is not a complication. Acute mastocytitis, that is clinical mastocytitis, in the that there will be red edematous soft tissue over the mastoid antrum. It will be painful, tender. Pinna is pushed laterally downward and forward. There will be loss of post-auricular crease. There will be autoria and localized reactive lymphadenopathy. There will be pain is the only presentation in the adults because of this thickened outer mastoid cortex. Now, what is the pathogenesis? As here in the picture you can see, first there will be Otitis blockage, it will be there. So what will happen? There will be failure of the drainage. There will be stasis of the secretions within the mastoid antrum. Hyperemic decalcification will be there. Resorption of the bony septa of the mastoid air cells. There will be coalitions of the small air cells to form a cavity. Then empyema of the mastoid cavity. It is a disease of the childhood also. More than 2 years of age it is common. Peak at the 6 years. Mostly it is a sequel of acute suppurative otitis media. The most common cause of which are pneumococcus and Haemophilus. 25% of the colons and mastocytitis are seen in the sclerotic temporal bone with chronic otitis media and cholesteatoma. Now, what is the fate of inflamed mastoid cavity? So, acute mastocytitis, if we give the antibiotics, there will be spontaneous resolution of the perforation of the tympanic membrane. If the acute mastocytitis persists, there will be blockage of the Otitis by the granulation tissue or the cholesteatoma. So, there will be collection of the pus within the mastoid antrum. So, mastoid empyema will be there. And if it persists, there will be demineralization, acidosis, osteoclast activity, pressure of pent up pus will be there. Acute coagulation mastocytitis will be there. Then from there, that condition there will be subperiosteal abscess, petrositis, and intratemporal and intracranial complications may arise. Now, which are the signs and symptoms? There will be autoria for the more than 3 weeks, pain behind the ear, and there will be fever, mastoid reservoir sign, that is pus fills up. When we remove the discharge with the suction or the mopping, again full ear canal will be filled with pus. There will be sagging of the posterior superior canal wall due to periostitis of the bony wall between antrum and the posterior EAC. That is, sagging is like it will move forward and inflamed will be there. Then there will be ironed out appearance of the skin over the mastoid due to thickened periosteum. Like it will be thick, harder you feel on the palpation. That is ironed out appearance. Then mastoid tenderness will be present. On touch there will be pain. The blood counts, we have to see for the blood counts, there will be raised WBC, raised ESR, mastoid cavity in the X-ray and the CT scan will show clouding. And then we have to do ear swab for the culture and sensitivity. Here you can see in the mastoid reservation from the perforation also, it is fully pus filled beneath with the pus. We can see through the perforation. Here, as you can see, as I told you, in the sagging there will be posterior canal wall will be pushed more forwards and anterior and it will be red congested. Mastocytitis, there is full red tender postal region, that is ironed out mastoid. This is clouding of the air cell, that is coalescence of the cells. Normally it is well pneumatized. Now, mastocytitis and furunculosis, how will it differentiate? So, in both there will be history of acute, here in the mastocytitis there is history of otitis media, while in the furunculosis there won't be. Here the deafness will be present, position of the pinna with downward, forward and outward in the mastocytitis, while in the furunculosis it is only forward. Ear discharge is mucopurulent in the mastocytitis, with there will be sagging of the extraordinary canal wall, congestion of the tympanic membrane, mastoid tenderness will be there, but there will be no post-oral lymph node. An X-ray will show coalescence of the air cells with cavity. While in the furunculasis, as you can see, there won't be any history of otitis media, any deafness, or sagging of the EAC wall, no TM congestion. But here, ear discharge will be serous or purulent. Position of pinna is pushed forward. There will be tragal tenderness, presence of posterior lymph node, but the X-ray method will be normal. Now, how will you manage? So, we have to do urgent hospital admission, broad spectrum antibiotics, we have to do cortical mastectomy. If no response to the medical treatment in 48 hours, and if there is sagging of the posterior meatal wall is there, then it is a development of new complication, presence of subperiosteal abscess. Myringotomy we have to do to drain out the pus. Incision drainage of the pus. Now, what is masked mastocytitis? That is when the natural progression of acute mastocytitis is halted by antibiotics. So medial layer you can see apparently normal. You can see free from the infection. Will be the persistence of the mastocytic. Within the mastocyte, the slowly infection, destruction of the cells, collection of the little pus will be continued. But with antibiotic in between, it will resolve. Again, after stoppage of antibiotic, again the infection will start. So in between on and off infection will be there. That is called masked mastocytitis. And here tympanic membrane fails to return to normalcy. There will be blockage of Otitis by the granulations or cholesteatoma. Now other complication is petrositis. Pneumatization of the petrous pyramid. Normally 30% anterior petrous apex, 10% posterior petrous apex after 3 years of age. Continuous with the middle ear cleft. However, there are two pathways, two chains, posterior superior tract or intralabyrinthine chain and antero-inferior or peritubal chain. As the name suggests, posterior superior means it will arising from the attic and antrum, it will go to the semicircular canal and then to the apex, that is petrous apex. Other one is antero-inferior. From the hypotympanum, it will go to the peritubal area, then cochlea, and then apex. Now, acute petrositis. It is also here the clinical picture will be deep-seated retroorbital pain. It is seen in 50% people. Diplopia, that is lateral rectus palsy, it is seen in 25%, and otorrhea. So it is a triad. It is also called the Greden-Nichols syndrome or Greden-Nichols triad. It is a typical syndrome is rare, but it is seen. It is not pathognomic of apicitis. Similar presentation with extradural abscess at the apex we can also see. Cochlear-vestibular symptoms, facial weakness, and constitutional symptoms you can see. Now, what is petrositis? That is pneumatization of the petrous apex is not a prerequisite. Alternative routes of the spread is thrombophlebitis, osteitis. Now, long-standing persistent otorrhea discharging petrous tract with indolent symptoms. Long term, it will lead to high dose. Long term, we need high dose systemic antibiotics, myringotomy with chromat insertion. We need corticosteroids if the neuropathy is there. And we have to do the surgery if the abscess is there in the petrous apex or necrosis is there, and there will be no improvement after medical management also. We have to do simple cortical mastectomy and surgery in a hearing ear. It approaches to the infected air cells. Surgery in a non-hearing ear, we can do translabyrinthine and transcochlear approaches. These are the approaches for the petrositis. Now, involvement of the labyrinth, that is otitis interna. Most common complication of chronic otitis media with the cholesteatoma, that is otitis interna. Now, arch of the horizontal semicircular canal is the most commonly affected in 90%, because it is nearest to the antrum. In the medial wall of the mastodontum, you can see the one ivory white structure, that is horizontal semicircular canal. So it is nearest to the mastoid antrum. When there is a breach of the aortic capsule is there because of the resorptive osteitis, that is inflammatory mediated in chronic otitis media with cholesteatoma or granulation tissue, or there will be pressure necrosis, that is cholesteatoma mass or cholesteatoma and or granulation. Presentation of the labyrinthine fistula. There can be sensorineural hearing loss, subjective episodic vertigo will be there, positive fistula test will be there, there will be Tullio phenomenon will be there. Preoperative CT scan when 30-degree tilted, 57 to 60% sensitivity even with 1 millimeter cuts. Intraoperative diagnosis. To present the presence of labyrinthine fistula to be assumed to be present in every case of chronic otitis media with cholesteatoma. Fistula test in relation to labyrinthine fistula. What is fistula test? When we do tragal pressure, alternative release and pressing the tragus, or we do with polyzip brake with ear canal adapter, when we change in the pressure within the extraoratory canal or with the pneumatic speculum, what will happen? There will be conjugate ocular movements with vertigo. It is not a sensitive in absence, so it doesn't rule out a labyrinthine fistula. So when we do this pressure changes, there will be ocular movements will be there. So when it is positive, that is called positive fistula sign. When it is negative, it is called negative fistula sign. Positive fistula sign we can see in the when there is a actual fistula will be there, that is a labyrinthine fistula will be there. Now which are the false positive fistula sign? False positive fistula sign, it is also called Hannibal sign. As the name suggests, false positive means it is not positive. Okay. It should not be positive. When the intact tympanic membrane will be there, but there will be no fistula. It is characteristic of labyrinthine syphilitis. It is not a diagnostic. Here, the fistula is not there, but still on pressure changes we can see the nystagmus. Now, what is false negative fistula sign? Here, as the name suggests, the fistula is there, but there on pressure changes there won't be any nystagmus. It is an inadequate seeding. The cholesteatoma when breaches the fistula, but there will be wax in the extraordinary canal, or cholesteatoma itself will seal the fistula. Or it is also seen in the dead labyrinth. That is false negative fistula sign. Now, what is the treatment of labyrinthine fistula? We can do tympanomastectomy, that is canal wall down mastectomy with addressing the fistula. That is removal of the cholesteatoma we have to exteriorize the fistula covered by the matrix, that is single setting in open cavity or stages in the closed cavity. It prevents aggravation of the sensorineural hearing loss by minimizing the tissue handling. Removal of the cholesteatoma itself receives the pressure, keeping the matrix safe until no granulation tissue lies underneath. That is, we have to remove this overlying diseased structure like granulation tissue is there or cholesteatoma. Now, complete removal of the cholesteatoma including matrix, single or staged second look setting, or repair of the fistula with fascia or bone plate. We can do one stage surgery also, we can do two stage surgery also, and we have to do prevention of the bone erosion and infection and prevention of the sensory neural hearing loss in the long term. Now, what is serous labyrinthitis? When the translocation of toxins and inflammatory mediators associated the mediators, so there will be associated labyrinthine reaction. Infection will be there, especially the fistula. When the serous fluid is there secreted with fistula infection, so it is called serous labyrinthitis. It can be due to the it can be tympanogenic, it can be meningogenic. That is pneumococcal meningitis will be there, and from the aqueduct cerebral aqueducts it has spreaded to the labyrinth, or from the middle ear infection it has spreaded through the round window or through the interauditory canal to the labyrinth. There will be sudden onset of vertigo in a patient with acute otitis media, So we can say that the patient might have serious labyrinthitis. We have to give higher IV antibiotics with we have to do myringotomy with mastectomy in progressive cases. Patient might have hearing loss, vertigo and imbalance are reversible. Here, when patient is still the stage of serious labyrinthitis, the imbalance is reversible. Once you cure the infection, the patient might not have this imbalance problem. But when the pus formation starts, when the infection gets spreaded and the pus collection is there, so it will lead to suppurative labyrinthitis. In suppurative labyrinthitis, there will be severe sudden onset of severe rotatory vertigo with vomiting will be there, and there will be profound unilateral deafness, disorder of the balance, and the disorder of the balance will want get treated even after infection gets cured also. There will be spontaneous horizontal nystagmus also. It is comparatively less common. There will, there will be invasion of bacteria into the labyrinth, or as I told you, it can be tympanogenic through the round window, through the fistula. It can be hematogenic through the venous channels. It can be endolymphatic hydrops, that is persistence of the Reisner's membrane to the bacterial invasion. It can be due to meningitis, intracranial or cerebral abscesses also. Tissue destruction will be there and loss of functions are the permanent. We have to do this myringotomy with labyrinthine sedatives. We have to give corticosteroids. We have to do mastectomy plus drainage or labyrinthectomy, and associated with there we have to give IV higher antibiotics. Now the last one is the facial nerve paralysis. As we all know, the facial nerve path is through the walls of the middle ear. So, when the infection is there within the middle ear, or when the facial canal that is surrounding the facial nerve is eroded due to infection or cholesteatoma, so the facial nerve gets involved. Now, in the otitis media, in 3 to 5% there will be incidence of facial palsy. It is more common in the children after acute suppurative otitis media. It is acute onset in less than a week in acute otitis media, or chronic protracted course in the chronic otitis media. There will be cholesteatoma formation, granulation tissue will be there. There will be suppurative labyrinthitis also. There can be petrous osteomyelitis also. Congenital petrous cholesteatoma, when there is progressive palsy with long-standing severe deafness without otorrhea. When the facial nerve is exposed by the cholesteatoma, mostly escapes facial palsy. Epineurium is replaced by the matrix. Now, what is the causes of the facial palsy? It can be seen in acute otitis media or chronic otitis media. In acute otitis media, it is due to neurotoxic effect, that is inflammatory mediators, bacterial toxins through the natural dehiscences and vascular channels. Mass effect on the bare nerve. In chronic otitis media, because of osteitis, erosion and direct pressure, due to edema, neuropraxia or neurotomesis also can occur. Cholesteatoma is more than the granulation tissue over here. Acquired fallopian canal dehiscence will also be there, or there can be tuberculous otitis media can also be the cause. What is the management? We have to first rule out it is can confirm that it is lower motor neuron palsy only. We have to differentiate it from the upper motor neuron palsy. Then the role of the CT scan. It is not a routine procedure investigation of the choice. We have to get less than 2 mm cuts with proper exposure of tympanic cavity and the facial nerve. We have to give IV antibiotics plus myringotomy with grommet insertion in acute otitis media. Or in the chronic otitis media, we have to do surgical exploration, that is canal wall down mastectomy, modified radical mastectomy, removal of the cholesteatoma in the granulation tissue, facial nerve decompression by removing the matrix from the epineurium. And also we have to do nerve repair if it is needed. Thank you. That's all. These are all the complications of the chronic suppurative otitis media. Thank you.